So this is going to be a short screencast on bronchiectasis as part of the pathology recognition workbook for the PRP module. So bronchiectasis is defined by the permanent and abnormal thickening of the bronchi that occurs following very long-standing and progressive inflammation and infection, and the sort of chronic and ongoing nature of inflammation being a breeding ground and a very good medium for infection, then that triggering off a further inflammatory cascade causes this long-standing inflammation and scarring of the airways, and obviously you get a significant amount of sputum production. So it's often diagnosed on a history of a chronic cough for patients that perhaps are younger than the chronic bronchitis age group, that have perhaps presented with hemoptysis as well as sputum production, but in the absence of a smoking history. So if you have a patient who is producing significant amount of sputum over a long period of time, so a period of months, but have never been a smoker, then you would start to do further investigations. It's often associated with immunocompromise. So when diagnosing bronchiectasis, history is an important factor, not only from a respiratory history point of view, so the recurrence of severe pneumonia, the presence of TB, or previous history of pertussis or whooping cough, but also the any other history of immunocompromise, and also any history of rheumatoid arthritis. And that in particular is quite important, because the literature suggests that there's a poorer prognosis of bronchiectasis patients if they also have pre-existing rheumatoid arthritis. In terms of bronchiectatic management, physiotherapy is really key to the management of bronchiectasis, because it's about treating the underlying cause to prevent disease progression, and then maintaining and improving pulmonary function. And as we know, the inflammation in the mucus and the sputum is key to that disease progression, and so physiotherapy to help airway clearance, be it breathing exercises, be it using adjuncts, very much encouraging self-management is really important. By improving day-to-day maintenance, you're likely to reduce the likelihood of an occurrence of exacerbations, which again are key to that stepwise deterioration in lung function. If your patients present with an exacerbation, so suspected infection on top of their usual sputum production, then an early sputum sample should be sent at the point at which sort of broad spectrum antibiotics are started. Once we get the culture back and have identified any particular microbe, then we can adjust the antibiotics as required. The other area that's important to remember is if the bronchiectasis is associated with any immunocompromise or any rheumatoid problems, then we need to ensure that there's joint management across the specialities. A useful reference here is the guidance for management of bronchiectasis, which was produced by the British Thoracic Society.